Good morning, everyone. I'm Spandana Rayala. I'm a pediatric palliative care physician. I also work as the Associate Director of Sunflower Children's Network, Two Worlds Cancer Collaboration. Today, we are going to talk about end-of-life care in children. By the end of the session, we want to be able to define what end-of-life is and how to identify end-of-life period in children with life-limiting illnesses. Also thinking about how do we communicate prognosis and goals of care with families, and how do we develop the plans, including anticipatory plans for common end-of-life symptoms, and implement an emergency kit approach for these families. It is interesting to see that Facebook has an option to have a legacy contact in case something happened to us. But we as healthcare professionals are uncomfortable, sometimes not trained, sometimes are not sure how to communicate about legacy, about end of life, about what is happening in a serious illness. This slide shows us that end of life care and terminal care are part of palliative care. Palliative care encompasses so much more than just end of life care. But end of life care is an integral part and is a very important part of taking care of a child with serious illness. This is the bow tie model of palliative care, which shows a possibility of survivorship and rehabilitation, but also a possibility of end of life care and bereavement. This particular model is more important in conditions where parallel planning is required, and we will talk about parallel planning in a bit. Looking at the definition of end of life, it is a period when a child has no realistic hope for cure. So this may span weeks to months or hours to days. The final 48 hours can often only be identified in hindsight. So there are several patterns of health before death occurs. So the first trajectory is when there are several complications that happen, causing a steady and a slow decline towards death. The trajectory 2 is a decline followed by quite a slow period of stability, and then there is a further decline of the child. And then there is trajectory 3, which is there are wide fluctuations, and this is when we are trying to prepare the family might say, my child is defying the odds because you have predicted death last time and it hasn't happened, and my child is stable currently, and they belong to trajectory 3. So how do we identify end of life period? Thinking about prognostication, we need to track changes in energy, activity, how are they communicating, play, their oral intake, to think about prognosis. And when we are having these conversations, we ask questions like, what do you see, to the family? And before we proceed to say what we see, we say, may I tell you what I see? And we avoid making firm predictions on time. Your child has 2 months to live, 3 hours to live, 2 weeks to live. Instead, we give a time span, and we will talk a bit more. When families ask questions such as, how much more time does she have? We do not have good prognostic tools for pediatric death. And as I said, we do not give time predictions. Instead, based on the deterioration of condition. For example, if the child is deteriorating every hour or every few hours, we predict that death might happen in few hours to several days. If the child is deteriorating daily or every 1 to 2 days, we expect death to happen within days to several weeks. And if the deterioration of condition is weekly, then we predict the death might take weeks to months to occur. And this is how we go with prognostication in pediatrics. This is the palliative performance scale that we use in adults to help predict the decline, help predict are they getting closer to end of life. However, we do not have a similar scale that is validated for children. What are the signs of imminent death? Are we able to predict death? So some of these symptoms are helpful in thinking about if the child is closer to death, such as progressive weakness, bedbound state, sleeping a lot more, poor oral intake of both food and fluid, difficulty to swallow, thinking about delirium, decreased consciousness, noisy breathing, abnormal patterns of breathing such as apnea, Chine-Stokes breathing, but also mottling and cooling of extremities. So when all these are happening, how do we start planning for the end of life? So this is when we start thinking about, what do we know about the disease? What is likely to happen? Number 2, child's fragility. Does this condition, is this child at a risk of sudden deterioration? Number 3, this particular family, how much information, how much guidance are they looking for? Thinking about communication and care planning for children. End of life care is a good preparation of family through communication, recognizing death and anticipatory planning, and pain and symptom management. And this includes use of opioids, and also thinking about who makes up the environment of the child during end of life. When people went back and looked at what are the elements of a good death, it usually includes adequate preparation for the death by the patient and also the loved ones, and thinking about how do we give a sense of control and dignity during this difficult period of time, spiritual and emotional support, and making sure they're not alone during this difficult time. And then thinking about adequate pain and symptom management, avoiding a prolonged dying process by aggressive, intensive measures, and also clear communication about decisions between the whole team, the child, whenever possible, the family and the extended family, all become a part of a good death. And as death is closer, I think it's very important for us as healthcare professionals to make sure what are the families seeing, to know that what is their experience with dying? Does this family have any kind of experience before? What are they worrying about? What are their hopes? And this includes what is the preferred location? Who should be present for them to provide them comfort? And also ensuring that the families know that all bodies go through similar changes near death, regardless of the diagnosis, whether it is cancer, non-cancer, and also to remember that families value honesty and timely information about what to expect. And some families, we might have to take permission ahead of time to keep sharing updates about what we are seeing. And again, we can never be certain that this is the time the child will pass away. Instead, we keep a track of what are the patterns of changes happening as the death is close. What does evidence tell us about what parents want us to say when their child is ill? One, they want reassurance that everything appropriate is being done for their child. They need respect for them and their decisions, good pain management for their child, understanding of their family's unique needs and support for siblings whenever possible, clear and honest information, and reassurance from us, the healthcare professionals, that they are good parents. And when sharing information with parents at end of life, always begin by asking, tell me what you are seeing, and then take permission. Can I share what I am seeing and what I think is ahead? And also remembering to gently say, I see that she has not been eating for several days and her body is weaker. What do you see? This is what I see that is happening. And then going on to explain the signs of dying, the ones we have already discussed, such as the child doesn't need as much food or water currently. As you can see, the breathing changes are part of what we expect. The child is now not passing urine or the hands are very cool, and this is again an expected part of the process. One of the difficult questions we get asked during this time is how much time does he have left? And when that question comes to us, it's important to acknowledge, initially thanking the family. Thank you for sharing your questions. Many families wonder about this. And then, as we have already discussed, going back to uncertainty, it can be difficult to predict what will happen and when. Function, I'm worried that the changes we are observing means that he's nearing the end of his life. And that is why he's sleeping as much and he's unable to tolerate his feeds. And if they are specific about their time, we might go ahead and say time is very difficult to predict in children. I wish it were different, but I'm worried the time may be very short now. And there is a framework which we have discussed in communication about wish, worry, wonder. If a parent asks a question such as, will my daughter be able to go back to school? I wouldn't say no or close the conversation. Instead, I would go with, I wish that things were different and I worry that is not likely given what she's going through right now. I hope that she will be here and I worry her health is deteriorating very quickly. And I might also say, I wonder if you feel that you had enough information to take the right decision for you, for your child, and for your family right now. During these times, it is quite common for healthcare professionals to say something like, do you want us to do everything? And this is not a statement that is encouraged to be used, because the everything of a healthcare professional is quite different from an everything of a parent. Instead, we might say something like, as her condition progresses, as she gets more sicker, we want to make sure she's as comfortable as possible. So if her breathing were to slow and stop, we know that putting a tube in or pushing her chest would not change things. What she wants you to do is hold her and comfort her. Families look to guidance to us at this time, and we might have to remind families that here are some of the things that you can do to her, you can do for her, such as holding her hand, cleansing her mouth, singing a song, telling stories, and also reminding them if they want to include their extended family in this process, reminding them to take pictures. You might want to hold her while I take a photo. This can be a precious memory. And also helping them say goodbye, especially for older adolescents and young adults. Please forgive me. I forgive you. Thank you. I love you. And also thinking about younger children. I'm proud of you. You will always be with me. You will be in peace. I love you. Whenever possible, with parental permission, make sure to include siblings, especially to reduce fear and isolation. And also keep the school updated so that the school can provide support to the siblings but also to the classmates. And the grieving process, every child grieves differently, and their level of development and understanding about death will affect how they behave and how they react. Here is a website, kidsgrief.ca, that might help parents understand more about how to support their children with grief. And also there are several books out there, such as The Invisible Strain, When Dinosaurs Die, which help families but also children to talk gently about death. Decision making at end of life. End of life priorities. To make these decisions, we need to understand what the priorities of end of life are for these families. So the families say that complete and honest information, easy access to the medical team, coordination of good communication between the team and the family, and emotional involvement, and also signs of support, solidarity from the team, spiritual support, that is faith-based support, and also preservation of the integrity, that is still being able to be a parent to that child who is dying. All of these are priorities of the family. As we have discussed, there are several trajectories in children with serious illnesses where it might seem like end of life, but the child might stabilize after a relative period of instability. And that's why parallel planning becomes very, very important. Parallel planning is a planning that accounts for this unpredictable trajectory we are talking about. So it involves multiple plans at the same time and then choosing which fits best for this particular child. The things to discuss during decision making are goals of care and resuscitation status, thinking about where do they want the care, the location of care, symptom management, advanced care planning and emergency kit, and end-of-life care preferences and wishes of the family. Goals of care discussions are to decide a common goal for the healthcare professional, child whenever possible, and the family to make sure we all understand what is being hoped from medical interventions. And these are shared decision making between the parties mentioned. While we all share our treatment objectives, we need to remember that they might not be achievable because ultimately goals of care are limited by the limits of medicine. And thinking about the shifting goals of care. So a lot of the times we hear that families want the child to be cured. So what else will they say? So always to remember cure or live as long as possible might be the goal of care initially. But when the family understands that the cure is no longer possible, when we explain it to them clearly, they usually shift to prolong the life of my child for as long as possible and keep them as well as possible. That is with good quality. And then it might shift to optimizing comfort at end of life. When we know that end of life is inevitable, when the family understands that, they ask for a comfortable end of life, a symptom-free end of life. So how do these goals of care conversation happen? Initially, we begin with assessing the understanding of the family. What do they know about what is happening to their child? Explore values and priorities. That is what matters most to them. Then thinking about sharing prognosis. So using clear, compassionate language. Identify goals. Are they still thinking about cure? Are they thinking about prolonging life? Or are they thinking about optimizing comfort at this point? And always remember, we as healthcare professionals need to recommend a treatment or intervention. And then make a plan and make sure we document the plan so that the whole team is well informed about it. Advanced care planning. Advanced care planning is again thinking about what the future is going to bring and what needs to be done medically. It is not a single time event, instead it's a process which changes based on the changing condition of the child. It might include short-term goals but also long-term goals and treatments that this family wants. And also thinking about anticipated symptoms, clinical decline and serious deterioration. The reason why we go for advanced care planning is to give children and their families an opportunity to identify what is it that they want from the medical care. And this is usually based on their personal beliefs, values, and wishes. When advanced care planning was done, parents are likely to have less decisional regret, have reported less suffering of their child at end of life, are better prepared for the end of life of their child, and also have the ability to choose or at least express what they want for their child's end of life. Thinking about planning the resuscitation status, early discussions with hypothetical situations and hypothetical circumstances are helpful for families and children. So thinking about discussing prognosis and making sure we understand what the family understands, and also eliciting goals of care in light of understanding of prognosis. And also we always recommend what is good care and what would not be good care. And again, this is a statement we have used before, and this includes if her breathing were to slow and stop, us putting a tube in her chest or pushing her chest would not change things. What would be best for her is for you to hold her and comfort her. And this is a recommendation, but also making sure that this aligns in the goals of care of the family. Thinking about symptom management that is required during end of life. Parents need to know what to expect, and this falls under anticipatory guidance. Families don't have a prior experience with the death of a child many times, and also to make sure families have a clear written plan and a named contact so that they are reachable 24/7. And especially the signs that they see towards the end of life, we need to keep reassuring and reminding the family that these are normal at end of life. Thinking about some of the common symptoms at end of life: physical fatigue, pain, poor appetite, nausea, vomiting, swallowing issues, constipation, shortness of breath. These are some of the most common symptoms, but also there are symptoms such as seizures, delirium that need probably more planning and better management. So whenever we think about symptoms, we think about evaluation and assessment. We think about, is it possible to treat the underlying cause? Then we think about non-pharmacological, which are integrative and any rehabilitative therapies to help the child. And finally, pharmacological therapy, making sure the families have access to medications and there is a written plan on how to use them. And when the child is closer to end of life, it is very, very important to re-examine the current management. And this includes investigations. Should we be doing all this monitoring, all these investigations is something that we have to ask ourselves, because this would add additional burden to this family without changing any management. Medications. Also thinking about, are these medications serving any goals? So does this child continue to need prophylactic antibiotics at this time? Do they need vitamin supplementation at this time? And also monitoring. How frequently do we want to look at the oxygen saturation at this point? And whatever we do, we think in the terms of what are the benefits versus what are the risks at this point. A lot of decisions needs to be taken by the families at this time, such as artificial hydration and nutrition. As we said before, the child's oral intake might go down, and a lot of the families worry about their child's intake and they might ask to be given IV fluids at this time. Transfusion of blood products, especially in situations such as aplastic anemia, leukemias, families might insist that the child might need more blood products at this time. Again, we might have to consider transfusion only when meaningfully improving the quality of life of the child, such as there is severe dyspnea because of severe anemia, right? Because usually blood product transfusion would mean admission of the child at a hospital, monitoring of the child, and also the possibility of side effects during a blood transfusion. Non-invasive ventilation. Ideally, it should be discontinued, but this should follow a careful family communication. Oxygen. A lot of the times, oxygen doesn't relieve dyspnea in these children, especially who are hypoxic. So considering fan therapy instead and other mechanisms that were discussed before. Pain in the last 48 hours. If verbal, we can ask the child if they are having pain. If non-verbal, we might have to use scales such as FLAC scale, FLAC revised scale. And usually, even at end of life, opioids are the first line to treat pain. Morphine is the gold standard, but we might use other drugs based on the required. Reduced swallowing causes pooling of oral secretions, and this leads to noisy breathing, and this causes gurgling or rattling sounds. And this is very, very difficult for the family to listen to and might cause distress to them, while the child might be minimally conscious or unconscious and is not distressed by it. So how do we manage this? We might have to decrease or stop IV fluids or oral feeds at this point, because extra fluid will increase the amount of secretions. We might have to turn the child to the left lateral position so that there is some postural drainage. Avoiding oropharyngeal suctioning, because the more we suction, it is known to cause more secretions. Thinking about drugs such as anticholinergics, but again remember that they decrease the secretions only 50% of the time. And again, whenever we are giving any kind of medical management, pharmacological management, it is important to balance benefits versus risk. Thinking about terminal delirium, A child at this point might not be able to identify, might be pulling their bed sheets. At this time, we think of this as terminal delirium and need to provide a calm, safe environment for the child. And we guide the parents to talk to their child and not correct them at this time in case they say something that is not correct, and sitting next to the child, and usually the parents' presence soothes the child and calms the child. We did talk about emergency symptom management kit, and this is especially important for families who prefer home as the location of end of life care, and preparing medications such as benzodiazepines, opioids, anticholinergics to make sure we are controlling the most common symptoms that might occur during end of life, and giving a written plan to the family makes a difference. In spite of written plans, the family might worry during the time when these symptoms come up. So giving the family a phone number which they can reach 24/7 so that they are guided on how to manage these particular symptoms becomes very, very important to facilitate a home end of life care. One of the most challenging discussions that we have during end of life is around poor oral intake anorexia, because the family comes up with questions such as, if we don't feed her, she's going to starve to death, she's no longer drinking anything, or won't she get dehydrated? So our usual responses are, as children approach death, decreased appetite and thirst are natural part of the dying process, and they don't cause suffering. And instead of focusing on IV fluids and making sure the child is eating enough, we might guide the parent towards making sure that they're more comfortable, such as wiping their mouth with a wet cloth, making sure they're positioning the child, and also if the child is able to express what they want, ensuring that they get that. For example, we have had children who asked for an ice cream for breakfast when we let them have that, because the focus is comfort and not nutrition at this point. And as the child becomes more weak, swallowing might be more difficult, and if we force them to eat at this point, the child might aspirate. Artificial hydration and nutrition. This is not known to prolong life or reduce thirst or hunger, especially when the child has days to weeks to live. And the risks that are associated with these IV fluids, the NGT feeds, are respiratory distress, aspiration, third spacing, that is pleural effusion, ascites, and also increased secretions causing noisy breathing. So sometimes it helps to remind the family that the body shutting down and giving this is not going to help, instead might add more burden to the child. But this has to be done culturally sensitively, because a lot of the families insist on going forward with this. And when they insist that they need IV fluids, that they should get IV fluids, we counsel the risk and the benefit, but then we say, let's try it for 1 to 2 days, or let's try it for 12 hours and see what happens. And then we go ahead and stop if we do not see any added benefit. And if there are complications such as the child starts vomiting or has extra secretions, we stop it immediately, because we need to emphasize the goal as comfort of the child. Several of these children, as I said before, might have terminal delirium. That is, they start changing their positions a lot. They might have visions at this time. They might not recognize their parents. And it is important to remind these parents that these behaviors are caused by changes in the body during the dying process, such as less oxygen to the brain, less fluid in the body, and the kidney function is lowering. So again, reminding the parents what can be done about being there for the child, and also considering drugs such as haloperidol if need be. Location of care at end of life is equally important for families to discuss ahead of time and to choose. Hospital, usually when there is complex symptom management involved and the family thinks or identifies that they need 24/7 support. Hospice, again geographically they are limitedly available, but it makes sure that there is a specialist available and the bereavement support continues after death at a hospice. Home is often preferred by many families in several cultures, and as discussed before, home deaths or home end of life care need good advanced care planning, provision of an emergency kit, but also 24/7 access to the family to continue providing clinical advice. And when we think about the environment where end of life happens, and this can be hospice, home, or hospital, think about space. Do they have enough space to be together as a family? Sensory. Is the sound too much? Is the light too much? Stuff. Does the family have and also the child have stuff that brings them comfort? Staff. The staff involved in end of life, do they have enough training? Are they keeping the family updated? System. The documentation, phone call access, all of this falls under system. Support and social systems. Do we allow visiting hours? Do we allow extended family to be involved? Do we encourage families to lean on their social support systems? Spiritual. I think one thing we cannot ignore during end of life is spiritual, which can be faith-based or including chaplains, imams, to make sure that these families are well managed during their spiritual turmoil. And to think about what does dignity mean in pediatric context. Thinking about the cultural aspects based on wherever these children are, thinking about privacy, thinking about choice. Have we provided choice to these families? Did we involve siblings? Are we addressing the developmental needs of the child? And when the child dies, it is important to remember that there is no rush after the death happens. The rituals need to be based on their religion or culture. Remove all lines or tubings from the body of the child. Offer family an option to participate in rituals such as bathing, dressing the body. Transport to the morgue, funeral home, or crematorium needs to be arranged in the background. Think about bereavement follow-up, condolence call, or letter within a week, and if the family needs to be referred to any grief support that is needed. Again, thinking about memory making, photographs, handprints, locks of hair, or other mementos. Here is some additional reading from the last few years. Guidance of Pediatric End of Life Care by American Academy of Pediatrics, 2023 Canadian, Approaching the End of Life for Pediatric Palliative Care Healthcare Providers. And then thinking about Society of Critical Care Medicine's guidelines. Thank you.